Welcome back, everyone. Today we're going to talk about dynamometers, in particularly inline pool dynamometry. And dynamometry is just a large part of the way I practice in terms of my model of care. And I feel it might help you guys with increasing your confidence in how to assess and treat an individual and help give you confidence in when to progress your patient's care in their rehab journey. It can also just really be helpful in guiding clinical decision making and giving treatment ideas and giving you an idea if your adaptation-led rehab is having an effect. So let's crack straight into it. Now, the first concept that we need to understand is resolution in testing. And Mitch has already spoken lots about this in his force plate little lecture, but it's just such an important concept to ram home. So if you think about resolution in testing, it's the smallest detectable change in quantity that a measuring tool can detect. So it's a measure of precision. How precise is that measurement? And so when we think of taking objective measures, we have high resolution tests and low resolution tests. So a high resolution test, it's very easy to detect small amounts of change. Okay, so that test can pick up changes really easily. And so if the test detects a change, there's probably a less chance that that change is clinically meaningful or matters, just because there's so much noise, it can pick up the tiniest little details in the test. And then a low resolution test is not precise, okay? It can't detect change that easily. And if the test can detect a change, well, then there probably is a higher chance of that change mattering or being clinically significant. So it's a bit wordy, but if we use an example of high resolution test, so in high resolution test, an example of that would be like your scales at home, like a digital scale that you go to weigh yourself on, right? So you weigh yourself one day, you have a massive feed, you weigh yourself in an hour, and what you've actually found is that maybe you've gone up 200 grams, okay? And so you look at that and you see that, the scale, the test is telling you things have changed, but does it really matter that it's changed? Not really. It's not really clinically meaningful, okay? But then when it might start to become meaningful is if you start to see, 5 kilos difference in that hour. That's when you're probably going, hey, what the hell's going on here? That's probably meaningful. So it's a high resolution test. It tells you change easily, but you probably only need to pay attention to it if it's actually telling you big changes. And then we have low resolution tests, right? Where I'm going to give you an example of something physios use quite often, and it's not precise, right? So if you do detect a change in it, then it probably does matter because it's actually hard to detect the change in the first place. And an example of this is a manual muscle test. Hopefully I'm not ruffling too many feathers talking about this, but manual muscle testing is a low resolution test. It's widely used. It's a tool that clinicians use to assess muscle strength and detect neuromuscular imbalances. But there are so many limitations with manual muscle testing. We'll chat about a few of them here. And a few limitations it might have is it has quite poor reliability and it is quite subjective in nature. If we look at some examples of inter-examiner variability, it is quite poor. So if you think about how different practitioners might rate the same strength, they might use different techniques to rate it. They might have different biases to the way that they perform the test or how they interpret the test. So inter-examiner variability is poor, but then also there is poor intra-examiner variability. So that's when the same examiner might rate muscle strength inconsistently over time or inconsistently rate the same strength, right? So an example of this is like if you're following up a patient every 2 or 3 weeks, and you're seeing 8 patients a day, how are you going to remember how much you pushed in, how much you were pushing against that person last time? So again, as well, inter-examiner variability, right? We have our own sets of bias. We want to see our patients improve. We have an inherent bias that is probably not conscious. We want to feel that this person's better. We want that our intervention has worked. So we have that bias that's just sitting there as well in the background that could be influencing the results of the test. And then if we think of the objectivity of the scale, right? I do think 0 to 3 is a little bit more objective because we do have an objective measure we're trying to assess. But when we start going grades 4 to 5, it starts to get a bit qualitative and it gets to be more the own clinician's judgment, and it starts to be a real subjective type of, I guess at what grade you feel the muscle strength is. So it lacks precise quantification and it's a bit subjective. Another limitation that manual muscle testing has is its lack of strength threshold sensitivity. So when we look to the literature, we know that we can't really uh, feel any difference below 20 to 40% asymmetries. And to me, that's just not good enough, especially when we have some literature, especially in the ACL world, where we want about 90% before we return to sport. Okay, so that's quite bad, and it's probably not good enough to completely rely on its own. And then again, we have that grade compression. So I'm talking that 4 to 5, where it's really hard to track subtle clinical changes. So those are two other reasons why it's probably just not very reliable and good enough to use on its own. So I don't think it's completely useless. Like, it's free. It just takes our hands. It's so quick to do. However, it doesn't provide us with a real objective resistance, especially in that 4 to 5 grading. Um, but I do think it has its place, especially in an initial when you want to quickly screen for any neurological deficits or sinister deficits there. And if you do find that there is a difference, it probably does matter. All right, it probably is significant clinically. But if you don't find a difference between muscle groups, it doesn't mean that that difference is not there or that asymmetry is not there. Okay. And that's just some of our references there for that part of the slides. Then we got the handheld dynamometer. So we're sort of going up in resolution now, but I tell you what, a lot of people trust their handy handheld dynamometer a little bit too much, in my opinion. So I'm just going to go through a little bit about the handheld dynamometer now. And, looking to the research, the handheld is highly reliable when used correctly. Now, this is where we get it wrong, and this is where a lot of clinicians are getting it wrong. They think, oh, look at this, I've got a fancy little device, it gives me a number, so all of a sudden I'm being super objective and I'm so good and I'm tracking my patient's progress. But they're not using it correctly, and then that does throw the reliability out the window. So if we look at this study from Ertz and al., done in 2025, they looked at some standardized protocols for the knee, hip, and shoulder. And what they found was the more you stabilize the dynamometer, the more reliable the measurement becomes. And obviously, an externally fixed dyno is much more reliable than a tester-braced position, which is definitely more reliable than a freehand test. So reliability definitely improved with training as well. So the clinician's experience, right? If we delve a little bit deeper into this, I'll just quickly go through what ICC means. So ICC is the intra-class correlation coefficient. And I guess what ICC measures is how reliable and consistent a test is at getting the same results. So what it does is you test the same tester a bunch of times, and then you test different testers a bunch of times, and you see how variable the results are, and then you get a statistical measure of how consistent and reliable it is. So if we have a higher ICC, then that means it's, I guess, more reliable, and if we have a lower one, it's much less reliable. So then if we delve into these positions here, freehand testing was shown to be, quite moderate to good ICC, meaning, I probably wouldn't use it. It's probably not that helpful unless you're using it on weaker muscle groups. So it's sort of, again, this low resolution, not very reliable way of using handheld dynamometry. And I promise you, that's what a lot of clinicians are doing out there at the moment, and thinking that they are getting reliable and consistent results, and that their measurement is reflecting changes in the individual when it could just be measurement error and inconsistencies because they're only freehand testing it. So I don't think it's really relevant to do much of this type of testing, especially given those results there. And it's definitely not suitable for strong athletes or research because of that poor ICC. But then when we use tester brace positions, so like the testers utilizing their body weight and being quite stable in the way that they are doing a freehand test, they're not moving. That's when we start to get good to excellent results in ICC. And so I think this is the minimal entry point where you really, if you're going to use the handheld dynamometer, you should really try your best to standardize a tester brace position at least. Okay, because I think this is clinically reliable enough. It's quite quick and easy to set up, and if you get a bunch of measures, you probably can see that error that you are getting. And if I think that's just the minimum that you should really use. But then if you really want to really lock in and get good results, we can actually see the handheld is really reliable and excellent at in its ICC when you externally stabilize it. Okay, so this is when we use the highest test. This is when we get the highest test and retest consistency. And similar findings in this Mazzucato and all study in 2023, they actually just measured dynamometry of the wrist, but they again found that, reliability is much higher when protocols are standardized, the limb was properly stabilized, the tester used a braced or fixed position, the same joint angle and dynamometer was placed consistently, and you gave the person similar instructions. So it's all about standardizing and having a nice fixed position when we use handheld dynamometry. But again, if you don't do all that stuff properly, you just get really poor reliability. So the test means nothing. Just because you're getting a number, putting something on a joint and getting a number, if you're not doing it standardized and that, you're freehand testing, it's really not that. It's not that good. You may as well not be doing anything. Garbage in is garbage out is what they say. So if we just go through all of these individually again, and it will give you, I'll just hopefully ram it home. There's limitations in handheld dynamometry depending on the rate of strength dependency. So the accuracy of the test is definitely compromised if the examiner is not strong enough to resist the person's force, right? So in a knee extensor, if I'm freehand testing that, I'm not strong enough to hold a knee extensor, especially in a strong individual where you can produce large amounts of force, well over 1 times 2 times body weight if you can. So that's not a good idea to do, especially in freehand testing. And then also, handheld dynamometry, especially if it's not externally fixed, is this complex relationship between how much the patient feels the therapist can resist and how much the therapist feels the patient's going to resist, to try and keep it isometric, especially when we're doing freehand again. So it's like this complex interplay of the two central nervous systems of the therapist and the patient. So it's quite limited there if we're freehand testing. Again, the more you have experience in using the handheld dynamometer, you know where to stand, how to brace yourself to ensure these well standardized positions. And when you're learning, you're moving all around the place, you're probably not pressing on the right spots, it's not as standardized. There you go, you get a limited test. Again, it can be quite hard to stabilize the handheld dyno, so a lot of joints are difficult to stabilize, therefore they're not really worth doing. Device variability, so there is evidence to say, if you use the same device throughout the whole clinic, that's fine, but if you try and interchange the devices, it can get less reliable and it cannot be interchanged in some devices. And then there's so many protocols for standardization out there, but there's no universally accepted one, and there's a lot of variability in positioning, where to apply the resistance and how to interpret that. So if I don't want to call out VALD, but some of their testing positions are influenced by balance. They're not, really stating a bony landmark that needs to be used. It's very free flowing. There's some freehand work there, which is it's just not reliable there. So we've got to be really careful with how we interpret and what joints we use when we test handheld dynamometry. And of course, there's a cost associated with it. It's not free, and it's not as cheap as a manual muscle test. So Again, handhelds do have maximum force limits, but that's probably one of the least limitations out of all the ones here. Little summary there, if you want a quick little summary, but it's everything we've already spoken about. So moving on, we have the gold standard in dynamometry, which is using isokinetic dynamometers, specifically the HUMAC norm CSMI is very, very reliable and valid. It's just very standardized, really, and it gives us some really good data and really cool data. However, it's not really realistic in most people watching do not have one of these. I only dream of having one of these. Hopefully in the future I get to, but if I looked a little bit a few months ago into Australian dollars, and this is what it looked like it could have been. Yeah, it's hard to get a price, but that's a lot of money. So I won't be touching that until I maybe can start to see 30 patients a day in clinic. So what this amazing study did by Norris and Eric and Seth is where I heard it from. Just listening to those guys talk, what they did was they used inline pool dynamometry, and they actually found that it provided reliable measurements of quadriceps strength in healthy and ACL reconstructed individuals, and it's actually a very valid substitute for your isokinetic tests. And so that gives us a lot of confidence, because you go, oh, you beauty, I don't need to spend 140 grand to get valid and reliable test results. And so what we can use is inline pool dynamometry. And there's a hell of a lot out there. So just a few examples there. We've got a crane scale, which you can purchase from Bunnings. The thing, before I saw crane scales, I just thought that as a weight scale for measuring the size of a fish that you caught. So I know it's used industrial, but yeah, they're not made to measure a person's force output, but they essentially are exactly what the valid inline pool dynamometer is, which is in the top left there, and then we have the tin deck there bottom right, which is another really cheap alternative to isokinetic dynamometers. So this is good news. So inline pool dynamometry is also a very valid and reliable substitute to more expensive dynamometers, again, when used correctly. Just because something spits out a number doesn't mean that that's automatically a good number and something we can actually use in our clinical reasoning. So I'm going to go through this a little bit later, so I'm going to sort of fly through this a bit quickly. But when used correctly, we need multiple trials with rest. So that reduces random variability. You can identify outliers if you do multiple tests, and it will improve your reliability there. If you rigidly externally fixate it, means that I don't have to, it's not now, the test isn't limited by my strength because it's fixed elsewhere. The dyno will be attached, it's immovable. It will prevent slack in the movement, any movement like in the handheld dynamometry. If you're doing tester versus patient, it does move around a little bit, but this makes it a little bit better. And then it ensures that the force is transmitted directly through that line if you externally fix it rigidly. And then we really want a consistent line of pull when we do this, okay? So that means we can ensure torque calculation, we can prevent off-loading, axis loading, and we can improve repeatability between sessions. And then 3 more that are really important is we standardize the positioning with joint angles, stable seat, no compensatory trunk or pelvic movement, and therefore we can create a clear torque calculation. And we just want to make sure that the calibration and the equipment is all consistent, okay? And that's a nice summary of the findings of that Norris and All study in 2024. If you do these 6 things, then you will find that you have a nice alternative valid measure to isokinetic dynamometry using inline pool dynamometry, which is much cheaper, okay? Feel free to take a screenshot. Now, if we're really on a budget, which I have been, so at Osborne Park Hospital, I set up a inline pool dynamometry using a crane scale, which only cost me $80 from Bunnings. So we can actually use crane scales. So it doesn't even have to be something made for strength testing. So what we found in this Dignazio and all study is that they have excellent retest reliability if you follow all those things from the Norris study. And there's strong concurrent validity when compared with isokinetic dynamometry, and they actually perform better than handheld dynamometry because it's externally fixed again. You have reduced tester influence. Again, a nice little screenshot you can do there, which actually shows why inline pool dynamometry is a preferred and probably more valid and reliable method than handheld dynamometry, if we can set it up nice and standardized. All right. So then comes the point in the talk where I will ask, what are we measuring here? What impairments are we trying to capture here when we want to implement one of these devices? So a lot of people will say strength. You're trying to see strength deficits. I want to see strength as a impairment, okay, comparing the sides. But I want to poke the brain a little bit and just ask, what are we really testing? Are we testing strength, as you say? And how I might describe strength is a multi-dimensional attribute that's influenced by many things. I sort of think about strength maybe as the potential of the neuromuscular system to produce force, so the potential. And then if we think about dynamometry, it's extremely difficult to capture this concept of potential of the neuromuscular system to produce force. And I don't think it does capture that, in fact. So what I suggest that we're actually testing, and what we are testing, is force. So I implore you to think that we're not testing strength, we're measuring force. We're measuring one snapshot of force under a very tightly set of constraints. And what force is mass times acceleration. So we are capturing the force that you're expressing at that one snapshot in time, not the full capacity or the potential that that person possesses. And the reason why it's not the full potential is because that test can be influenced by so many different things. If we just go through a few things here: muscle cross-sectional area, tendon stiffness, joint mechanism architecture, so not even the muscle but the joint, muscle architecture, neural drive, fiber type, psychological factors. What if the person's in pain and they have inhibition from that? What if they're fatigued? Okay, so if they're fatigued, they're not showing us their full potential during the test. What if they're not familiar with the task? If they are familiar with the task, what if they're not very confident in their knee? If you're measuring the knee extensors and you ask them to do this, they're not going to show you their full potential of their knee extensor mechanism to produce force. And what about if they're not comfortable? And what if they're not very aroused, like you're not screaming at them telling them to push hard, or if you're whispering telling them to push hard? So there's so many things that will influence their potential to produce force. So in that case, we are not measuring strength, we're measuring force. Sorry for being so repetitive, but it's just so important. I think we need to understand this. It helps in our clinical reasoning. So I'll tell you what it doesn't tell us. I'm going to keep ramming the message home. It's not showing us where the force is being produced. If we use the knee extensors again as a knee extensor mechanism, isometric, we don't know where it's coming from. Is it vastus medialis, lateralis, rectus femoris? We don't know which muscle the force is coming from. We don't know how strong the muscle is, or we don't know how much force can be produced throughout the range. We're only looking at that specific range that you set up in the dynamometry. We don't know if the person is limited by fatigue. We don't know if the person might be limited by pain. They might not tell us. It doesn't tell us how strong that person is doing another task. It doesn't tell us how strong that person is doing other contraction types, or how much force they can produce doing other contraction types. So last one is that it doesn't actually tell us the amount of contribution the factors from the previous slide have. So anything in that, it doesn't tell us. So we're not testing strength, we're measuring how much force can be put through that device at that point in time. So why does this stuff matter? And what are we actually measuring when we do dynamometry? And so there's quite a few metrics that can be spat out through a dynamometer. I think um, not many of them are valuable besides my bias, these two metrics. Now, I think uh, it's quite intuitive why peak force might be something that is really important. Okay, so what peak force is, it's the most reliable measure. So it's the easiest thing to measure using a dynamometer. So it's the maximum force output that someone can put through that dynamometer. Okay, nice and easy to measure and nice and reliable. Then we have rate of force development. Okay, so this is a lot more noisy. So it's essentially how quick someone can produce a certain amount of force. So how long does it take to get them to their maximum, or you can just take it at different time points, right? So how quick force can be produced. And there's a lot of noise involved with doing this in a isometric test. But these are the two metrics that probably matter the most. And why do they matter the most? Well, for starters, why does peak force matter? In order to complete a task, we need to be able to produce a certain amount of force, right? It's basic Newtonian physics. To do something, we need to be able to produce force to do it. And so if we take this into the physio world, the running world, okay, so through biomechanical loading profile studies, we have seen that internal loads on the quadriceps during running, depending on how fast you run, can be as great as 6 to 10 times body weight. And then if we even take this to the plantar flexors, it can be 6 to 12 times internal forces at the plantar flexors. And so this is to deal with some really high amounts of ground contact time and the ground reaction force. So we need to be able to produce these big numbers of internal force loads to counter ground reaction forces. So peak force does matter to be able to do those tasks. And then we use this type of information, and this can be extrapolated into the ACL rehab world or rehab world in general. And there is some literature to support that restoring 90% quads limb symmetry index or knee extensor force limb symmetry index can be beneficial in potentially maybe even preventing injury, but really preparing the knee for the loads it might encounter during some of these activities like running. Okay, and this equates to about 2.5 to 3 Newton meters per kilograms as torque to body weight ratio. And these numbers are based on some normative data studies. And then that is further extrapolated to some objective criteria-based rehab. So when we might want to consider returning to running, there's some evidence that says 70% limb symmetry index or 1.8 to 2.2 Newton meters per kilogram is what it would be beneficial to restore before returning to running. So your knee is prepared for those loads. And then we take it one step further and we go, okay, peak force matters, but why does rate of force development matter? And it's because you need to be able to produce a certain amount of force, but you need to do that in a certain amount of time to achieve a task. So the example I use, like you're going upstairs, right? You don't have 10 seconds or 5 seconds to produce that knee extensor moment to get up a flight of stairs. It would take forever. So you need to produce that force quickly, right? And then if we take this into sport and running, sorry, my face is getting in a way of a lot of references here, but changing direction, again, through biomechanical loading profile studies, we see that the quads during cutting peak knee extensor moments, they can occur within 60 to 100 milliseconds after foot contact. And this is as high as 4 to 6 times body weight, right? So that's a lot of internal loads needing to be produced, internal forces needing to be produced in a very short amount of time to do these decels and change of direction. And it's even larger in the plantar flexors, right? During deceleration, to stop peak plantar flexion moments, they were occurring 80 to 120 milliseconds after foot contact. And this is as high as 10 to 12 times your body weight. So again, we need X amount of peak force in X amount of time to do these tasks with high performance. Just some references there. And then if we then think about torque, right? So torque is essentially the rotational forces around an axis. So if we relate this into a human body, muscles produce force, so you can see that bicep there, and then that force is transmitted through the distal biceps tendon there, and that tendon will pull on a bone, and it will pull on a bone at a specific moment arm relative to the joint, so the elbow. And then the torque is what creates or resists that joint rotation. So it could be creating that rotation to to curl that dumbbell, sorry, or it could just be resisting the weight of that dumbbell and holding it there isometrically. And then this is taken straight out of Scott Morrison's physiopraxis site, but it really sends the message quite well. So he essentially set up these parameters, and there's two examples of a person set up within a knee extensor isometric inline pull test. And those scores of 100 on both of those, the top one and the bottom one, that's representing the torque created at the knee extensor, at the knee joint there, sorry. And so this might represent the same person on two different occasions. In the top example, we have a inline setup, set up as you should set it up. So 90 degrees with so inline perpendicular with the line of pull. So that's how you want to set it up. And so that moment arm as well was 0.55 meters because the person's tibia will not change in both of those tests. So that first one might be a Wednesday afternoon where you're locked in, you've set up the dynamometer in line 90 degrees as you should, as you've standardized. And then that bottom one is the Friday last patient of the day, and you've been a bit lazy in your setup and you've set up that line of pull to 70 degrees. All the other metrics are the same. So if we work backwards and figure out using that torque that we know is equal on both of those, and we see what the dynamometer is telling us, if we do the top one well, like we have, set it up with 90 degrees as we should have, we might tell the patient, look, unfortunately, your force expression has not changed that much since last time we did it. So 181.8 newtons is read on that dynamometer. So we'll say your intervention hasn't been effective in helping this person express more force, or there's been other factors that the person hasn't been compliant or so on. However, if you set it up poorly with a line of pull of 70 degrees and that person puts the same amount of torque is expressed through the knee, your dynamometer is actually going to show that there has been 212.8 newtons of force put through that device. Now, you're going to high five your patient. You're going to think you're a legend that you have helped this person improve so much. You're going to say, wow, my intervention's effective. He's such a good physio. But it's all under a fallacy because you really haven't changed anything at all. So this is why it's so important to set up your tests standardized. Okay, I'm going to go through that now using a lot of the Norris studies contribution here. So here we go. The first rule is we're going to use knee extensor as an example. We want to fix that dynamometer and its line of pull or push in line with the direction of force, perpendicular to the anchoring point. Okay, so you can see the dynamometer and the strap there, it's perpendicular to the force that will be applied to it. All right, so that's the first thing we want to do. And then the second thing we want to do is we want to use standardized anatomical landmarks to fix the dynamometer or the strap. I like to use above the lateral malleolus. It's nice and easy to feel, nice and easy and prominent to point out. So if we keep changing our bony landmarks, that's going to change the length of the moment arm, isn't it? So it's going to give us a different result on the dyno. So we want to keep it the same every single time. We also want to try and keep the same joint angles. All right, so we want to keep the same joint angles, and we want to also make sure that that joint angle is really optimal for the muscle length tension relationship that we're trying to capture there. Because there's no point trying to test a peak force uh, of the extensor mechanism in 0 degrees or full extension, because it won't be able to show us much. We also want to just make sure we are factoring in the surface support surface softness. I'm going to talk a bit about that in a second, but uh, depending on how cushiony the support surface is, so the seat that I'm sitting on, if that's super cushiony, then when I put tension through the device, my femur or my thigh is going to squish into that soft cushion, and it's going to then decrease my joint angle. Okay, so we want to make sure we factor that in. So sometimes if I'm using a cushiony surface, we want we want to factor that in. So I'll actually probably have them in maybe 100 degrees or 110 degrees, and then when they go to do that contraction, it then ends up being 90 degrees at the end. So just taking into account that, but making sure it's the same every time. We also want to use standardized state patient positioning. So we want to make sure that the patient's positioned in the same spot every time. So if I'm holding those handles like I've shown you there, I'm going to hold those handles next time. If I'm sitting my bum in the back of the chair, I'm going to do that also next time as well, and so on. You know, my foot's hanging off the edge there. I need to make sure I'm in that same position next time. Again, talking about the support surfaces, we want to use the same support surface. So what's important as well is that we don't want a support surface that's too hard, because if you have a hard surface, then maybe when you do a maximal contraction, it might hurt your hammies or just like the bottom of your thigh there. So then you won't put as much force through that device. So we want it to be soft enough that it doesn't hurt. But then if it's too soft, then you're going to lose a lot of tension in that device, and you're going to lose a lot of your joint angles. So we want a little medium ground there. Then we also want to minimize jerkiness and keep tension in the dynamometer the whole time. So my tension's maintained there. Like if I started in heaps of flexion and it was loose, then if I kick out really quickly, it's going to give us a really noisy test at the start, and it will give us probably some artifacts there. So we want to keep tension on it. And you can't see it here, but we want to maintain the stability of a person and minimize other joint movements. So then that test is really specific, right? So what Mitch has done here, he's set up, you can't see it because I'm wearing a black shirt, but he's set up a seatbelt around my pelvis there. So that stops me from, when I kick into that device, my hips aren't going to come off the chair there and sort of ruin the test. Because then it's going to, if my hips did come off the chair, then that test is no longer measuring my peak knee extensor force, but it's actually measuring how much it takes to lift my hips off the surface. We also want to ensure same warm-up test prior to the test. So I like to use 3 warm-up tests at about 50% of maximum. It just shows the patient, that it's not so scary, the device isn't scary. Just make sure that they feel comfortable, and I can eyeball and make sure the joint angles are correct and the person is nice and stabilized. You can do whatever you really feel you want. Sometimes you can get them on a bike, or just like a few lunges as well, that might help. But it's really up to you as long as it's standardized. This is one of the most important things as well. So we want to ensure the same instructions are given to your patient at each time. And we want to make sure that the instructions reflect what you're trying to find out. So if I want to find out the person's peak force expression, then I want to cue for peak force expression, right? So I'll say, I like to use when I say go, you have 5 seconds to build and kick as hard as you can outwards against the device. So I know that, usually there's literature to say that after 3 seconds, the muscle will fatigue and not give us as big a force, but I like to just control for, 0 to 5 seconds. You should capture the peak force there if they've got quite a slow rate of force development. So that's what I use. But again, use what you can and what you want to. And then you want to ensure the same data collection. So giving everyone equal sort of trials. What I like to do is take 3 trials and then I take the maximum, given that all of the trials are within a similar number. I think when you take an average, it doesn't really make sense because you're trying to see the peak force, not the average force. So it's up to you. You can take an average, but just make sure you do it the same every time. Definitely only doing 1 test is probably not good enough because you want to make sure that this test is, reliable and it's giving you a similar result. There's no outliers. And then we want to think about interpreting the result. All right. So when we do the tests, we need to think, what's this person's history? What might be influencing the test? Like pain, no pain. We want to think in the setup, how specific is the test testing what I want to find out? All right. So essentially, you need to sort of think to yourself, what do you think you're testing? And let's go through some examples here then. We got the mid-thigh pull. And so the mid-thigh pull is quite a non-specific test. It's quite a global measure of lower body and trunk strength in a powerful position, right? We're in a little mini squat position, but it's got so many joints involved, so many big muscle groups involved, like the quads, the glutes, the hamstrings, the back extensors, the upper body, right? So we're using a lot of muscles in this test. We need to then think, right? If no one's limited by pain, then beauty, we're sort of getting this load profile of this individual in this position. So how much force can they express in this position at this point in time? But then you can think about if someone has pain, let's give the example of back pain, we might no longer be measuring maximum force output. And potential of force output. We might be measuring now someone's load tolerance from that sensitive structure. So you're pulling up and you're trying to pull up as hard as you can, but you're limited. You go ow and you stop before you reach your maximum force output. So then all of a sudden that number is now capturing your load tolerance. So how hard you're willing to go with that sensitive structure. All right. So we can do this test like as a nice and easy load for irritable patients with lower back pain because there's a small moment arm at the spine there. So if they are super irritable, you could maybe choose this test and the back is probably going to be the first thing to go out, and then that will give you a number there for your patient's load tolerance in that position. And then, similar premise, we go to the mid shin pull and it's still really non-specific and it's a global measure of lower body and trunk strength in another powerful position. However, you need to think now there's an increased moment arm at the spine and the knee, and that means there's probably more contribution of the back extensors and knee extensors, and that's a little bit more dominant now. So then if you were to see someone with back pain and get them into this position, then it might be a bit easier to provoke them because it's more demanding on the back there. So if they were pulling on the mid thigh and they were saying, "Oh, no back pain," you could maybe try a mid shin, and that could then provoke some back pain and give you a number for load tolerance of that sensitive structure in that position. So we have now some 2 different types of setups for knee extension and also knee flexion tests. And I want you guys to think about these 2 different patient populations. We're going to do the exact same test to them, but what is each one maybe telling us a little bit more about? So let's say in that ACL reconstruction 3 months post, they have no pain. And so we might be more confidently capturing the person's peak muscle force capacity at the knee extensors or flexors, right? Because there might be some other factors contributing, but pain is not involved. So we're a bit more confident we're capturing how much capacity the muscle has to produce force. The muscles have to produce force. But then we set up that same test with a patient with arthritis. And that person is saying ow before they get anywhere near their peak force. So now we're measuring load tolerance of the knee extensor or flexor mechanism. So see how it's the same test, but you need to clinically interpret it differently. Again, I just want to show you as well the difference between this test and those mid-thigh and mid-shin pull tests is that this test is only much more specific to one joint. It's only at the knee that we're testing. The other ones are non-specific because there's so many joints involved. So in this test, you can be a bit more confident that the issue or the contribution lies within the knee extensor or flexor mechanism, where with the other one, we don't really know, can't have much confidence where the contributions are coming from, right? And then, we can do all types of different positions and setups with a shoulder, and we can put them in different positions there. And so this is a nice time to sort of just plug that Mitch and I are really happy to come and consult in your clinic, or if you just want to learn a little bit more about dynamometry, let us know. We can, have a scope of the clinic space, see what we might be able to set up there, and we can also help with some PD on how to interpret the data for different joint injuries or just different post-surgical rehabs. Lastly, we all know and we sort of all are aware of the idea of using dynamometry to capture peak force expression, but I like to use dynamometry also for my pain patients and my pain individuals, right? So if we contextualize and use chronic back pain as an example, this patient, let's say, has had chronic back pain for like a 5-year history. They are exhibiting all these things like protective behaviors, avoidance. They're guarding lots. They're not keen on exercise. They keep coming in each time they see you, that they're saying the pain isn't changing, and they're really pain orientated, pain focused. So it's hard to get the narrative away from there. Now, this is a good time where you could consider to use dynamometry and maybe the mid-thigh pull tests, okay? Because we're trying to now change the narrative away from pain to an objective number of force. So I might say, all right, pull up just as much as you can tolerate. So the patient's in complete control here and they feel safe because they can do whatever they feel comfortable doing. And I often will say, how much do you feel like you just lifted? And often, because these guys tend to have, a poor confidence and self-efficacy, they're likely underreport what they're lifting. So this is a great time to then create a belief violation by stating their actual score. So you're violating their expectations and their beliefs about how strong their back is. And this is sort of then utilizing a bit of cognitive behavioral therapy or cognitive functional therapy, and that's stuff out of Sullivan's group, but we're using an objective-based measure to track this, all right? And then we can use this measure to compromise with the patient. What if we quarter this weight and do it sitting down? Does that sound like an acceptable place to start? So all of a sudden we're making the patient feel safe. I just lifted 20 kilos. Of course, I'm happy to do 5 kilos seated, smaller range deadlifts. And then this is a nice gamified way for that patient to return and to maybe want to focus more on the number and being active and, buying into exercise that's being prescribed because it's matching their outcome. All right, so this is how we can now track improvements objectively rather than just asking about pain. Now, I just think it's a really handy way to really work with pain and especially chronic pain. So again, please feel free to let us know any questions you have. Hit us up in our Instagram, TikTok, YouTube, LinkedIn, and we're happy to just answer any of your questions, consult in any of your dynamometry services. If you're interested to know a little bit more, we're happy to come in and help you guys set it up in your clinic. Just reach out on email or our website. See you in the next one.